Great. So let's start with the mock test of today's 25th of the May. First questions in front of your screen, right? So this is the first questions. Try to utilize all your expertise here. 53-year-old man who works as a chef present to accident and emergency with sudden onset of severe pain, tenderness, and swelling of the first metatarsophalangeal joint. The pain is making it difficult for him to mobilize. He has two previous similar episode. Blood test reveals raised urate level. The most likely diagnosis is gout, pseudo-gout, septic arthritis, reactive arthritis, and osteoarthritis. Very frequently asked question in exam. Yes, so you can post your answer in the chat box. Let's discuss what's your thought process, right? And we'll rule out one by one. I would be glad if you post your answer because hardly one or two people are posting their answers. Yes, Ishrat. So what do you think? What is the answer, Dr. Ishrat?
So the answer
Yes.
is A, gout,
Mhm. Why gout? Why not pseudo gout?
because the patient have raised C
Sorry,
level.
because of what?
He have
So as I to,
raised
so as I
serum
told you
urate
last
level.
time, no problem. You are going great. So whenever you give any answer, first of all, try to make what point favoring your answer. So point favors your answer. So go one by one in the scenario. What point favors that you think that this is a gout, this is not, other options are not there. We'll rule out one by one. But you give me what are the positive findings or sign symptoms in this scenario which favors the gout. Yes.
First, severe onset, sudden onset of pain, sir. Another is swelling over the first metatarsal phalangeal joints.
So this is the most important swelling of the first metatarsal phalangeal joint, not metacarpal, it is metatarsal, right? So severe pain could be in anything, right? You can have severe pain even in gout, pseudo gout, septic arthritis. But the most important is the site of the pain. Number one, whenever you are answering any question with arthritis, look at the site. Look at the another thing, unilateral versus bilateral, right? Unilateral versus bilateral, right? So site of the joint, unilateral versus bilateral. Look at the fever, history of fever, which goes in favor of septis or septicemia or septic arthritis, right? So this is what the thing is. Look at the age of the patient, right? Look at the sex of the patient, female more rheumatoid arthritis and autoimmune is more in female than male. Age, elderly age more than 55, 60 years of age also increase the chances of osteoarthritis, right? So you need to look into this, all the parameters, right? So now what this gentleman has a first metatarsophalangeal joint, pain is making him difficult to mobilize, right? He has a similar episode, and this is the clue. Blood serum urate level is increased. So what do you think in which of the condition the blood urate level will increase? Which condition the blood urate level will increase?
Dehydration.
Yeah, so I mean here in this context of this scenario, gout or hyperuricemia, right? Gout or hyperuricemia, isn't it? Yes or no? At least tell me yes or no. Right? So serum urate level is also high. So considering this complete scenario, this patient is suffering from the gout. So answer for this question is gout. So our one problem is solved. What is the diagnosis? It is gout. Now tell me, Dr. Ishwar, how do you differentiate gout versus pseudo gout? Head-to-head comparison. Pseudo gout. Go ahead. Go ahead. Head-to-head comparison, gout versus pseudo gout, or septic arthritis, or reactive arthritis, osteoarthritis. How you gonna differentiate? What is the impression in your mind about the pseudo gout? Anyone, it's open for all. What's the head-to-head comparison? This is gout, this is pseudo gout. What's the difference? Tell me. Probably they may ask
Sir,
you in the exam about pseudo gout. Yeah,
so
go ahead.
during the Aspiration of the fluid in the gout, it shows the needle shape, and in pseudo gout, it's rhomboid shape.
Okay, so that is the joint aspiration, basically joint aspiration. So this is the one joint aspiration, right? You told here you can see urate crystal and you see this is a rhomboid, right? Fine, fair enough. This is what. What else? Apart from this, is there any differentiation or this is the only differentiation between gout and pseudo gout? Yes, Aisha, any comment? Dr. Noman?
Pseudogout
Yes, yes.
normally can be seen associated with electrolyte disturbances also, and hemochromatosis is also associated with pseudogout, whereas in gout it is more of diabetes and obesity association.
Fair enough. So this is related with some comorbidity or some other clinical condition. What else? What are the conditions? Yes, Dr. Lalita, any comment? Dr. Madhusha, Dr. Mohammed, Murod, Nasreen, Rishabh. Yes, anyone. Fine. So you must know it, right? If you don't know, you go and read it. I will give you each and everything in detail. So this is what the thing is, right? So this is a picture of classical picture of gout or gout trophy or gout trophy, right? So here is the gout trophy. What is gout trophy? This is metatarsophalangeal joint, usually seen in the lower limb and greater toe. Patient comes in the emergency room, right, with the severe, acute severe pain, right? Swollen and inflamed joint because of the deposition of urate crystal, uric acid accumulation, and this is the crystal, urate crystal because of high uric acid, right? So this is absolute classical, right? So just remember this picture. It comes in the exam. You can answer it very easily, right? So this is urate crystal or gout. Now let me tell you the head-to-head comparison of all five conditions because they probably ask you anything in your exam. So I don't want you to miss anything. So let's go first gout versus pseudo gout. So we have five conditions. One is gout. Second is pseudo gout, psoriatic arthritis, osteoarthritis, rheumatoid arthritis. So five condition, how we gonna differentiate one head to head, right? So first of all, epidemiology means age and sex. So gout, female is more than male, female is more than male. This is general, not a rule of thumb, but this more common in female than this, right? Sorry, more common in male than female, right? More common in male than female, right? So, number one, peak incidence is 30 to 60 years, 30 to 60 years. Our patient at the age of somewhere 53, 54 years, right? Pseudo gout, male and female are same as per the epidemiology, and majority of the people, they usually have more than 50 years of age. So basically, by age, you probably may not get differentiate, right? Right? Because this is more than 50, this is also around 50 to 60, right? But if it is some patient comes to you at the age of 30 years, then it is less likely that it is a pseudo gout because you need to keep this age in mind, more than 50, usually more than 50. That is why I told what important in differentiating all this arthritis is number one, age. Number is second is sex. Risk factor. Let's see the risk factor, gout and pseudo gout. So risk factor for gout, family history of gout, right? Family history of gout and extremely important. Sometime in history, they say that patient came into the middle of the night after uh, heavy drink, presented with the right metatarsophalangeal acute severe pain, blah blah blah. So heavy drinking history is extremely important, which precipitate the gouty attack, right? So this is why that is why it is the risk factor. Pseudo gout, there is no family history. You can see there is no much family history. History of joint trauma and chondrocalcinosis and hyperparathyroidism. These are the risk factors for this pseudo gout. Let's go to the next slide and try to finish gout versus pseudo gout. So this is epidemiology and risk factor, right? So what are the other differences between these two? So let's see what are the other differences. So here this is gout, this is pseudo gout, right? As you see it in this picture, right? So this is gout, Second last is pseudo gout for your knowledge. Continuation, right? So we seen epidemiology, we seen the risk factor. Now we're gonna see another factors as well. So course of the disease. Sorry. So in gout, what is the course of the disease? Chronic progressive course. Chronic course with acute attack. Right? This is chronic progressive. Even in gout, it could be acute as well, like this patient, right? A clinical feature, extremely important clinical feature in gout, right? So here you can see, one second, right? So here you can see, sorry, I missed this part. Pardon me. This is here. 1, 2, 3, 4, and 5. Sorry. So here the gout eventually develop a tophy. That is what we seen in the metatarsophalangeal joint. And in pseudo gout, chronic inflammatory arthritis in pseudo gout is a rare and resemble RA. Morning stiffness and constitutional symptoms are also there. And last but not the least, right? How it behaves. This is gout and this is separate. Last one is a pseudo gout. Don't get confused. Don't get confused. Yes, right? So 1, 2, 3, gout, pseudo gout. Usually monoarthritis. Usually monoarthritis. So joint involved is monoarthritis. Typically, location include the big toe, metatarsophalangeal joint, as in our C, right? Knee and thumb joint also can be involved, but classical, the most important is the metatarso in grade. And it is monoarthritis, rarely oligoarthritis, and commonly knee and wrist. So commonly knee and wrist. It is not the great toe, or it is not the metatarsophalangeal joint. It is in the pseudo gout. It is not there. So this is also very, very important point in the differentiation of pseudo gout versus gout, right? And last but not the least, how you differentiate in various aspiration. So gout, what happens in gout? Hyperuricemia, uric acid is obviously increased in this. Synovial fluid, negative brief finger or needle-shaped crystal, which is positive here, right? So this is the rhomboid-shaped, recently doctor told, right? So when you aspirate synovial fluid of the gout, right? You should not see such a rhomboid, right? Crystal. You can see here the urate crystal, here the rhomboid crystal, right? And imaging, if you go through the head-to-head comparison, gout versus pseudo gout imaging, right? So here the rat bite erosion with overwhelming cortical bone in advanced cases and chondrocalcinosis, as we see in the risk factors. So chondrocalcinosis and treatment, you must be knowing the treatment of both the things, right? So it's important. So can anyone tell me what is the treatment of gout and what is the treatment of pseudo gout? Can anyone tell me what is the treatment of gout here? It is not mentioned here, but I'll just ask you. This is again a very favorite question. Treatment of gout. So acute episode of gout, chronic episode of gout. And what is the treatment here in pseudo gout?
Acute, both in gout and pseudo gout, acute, this one we will have anti-inflammatory, sir, NSAIDs, or if that doesn't work, then colchicine is also preferred.
So NSAID, colchicine is also preferred. If nothing works, then steroid is also helpful. Steroid is also treatment of choice, right? But first treatment is the NSAID. If patient has a chronic
Yes.
hyperuricemia, what could be the treatment?
Urate lowering drugs, allopurinol or febuxostat, and
Urinol or febuxostat. Excellent. And what is the treatment of pseudo gout?
it is usually treated like arthritis, sir, methotrexate or HCQS, disease modifying drugs.
So can you name the disease modifying drug?
Methotrexate,
What do you mean by
HCQS.
disease modifying?
These drugs actually are not symptomatic. They change the path of the symptoms. I mean, they lower the severity of the joint malfunction or joint disintegration.
Any other comment from any other expert? What is the treatment? Is it correct this disease modifying agents are useful in pseudo gout?
Sir, in pseudo gout, we treat the underlying cause. Like if it is due to hyperparathyroidism, we treat it. If it is due to, so we just treat the underlying cause, not DMARDs.
Excellent. Yes. So basically it is like treat the underlying cause and the treatment is absolutely same. All three. You use the NSAID, you use the colchicine, and you can use the steroid for pseudo gout as well. Right? So those who don't know about gout and pseudo gout, this is absolutely very, very high yield questions for the exam. Right? So you must know the gout versus pseudo gout, which we usually avoid, which usually I've seen people are avoiding, right? Not knowing the pseudo gout. So it is very extremely important, right? So gout and pseudo gout is also important, right? Can anyone tell me what is the head-to-head comparison with with rheumatoid arthritis and osteoarthritis? Another question, right? In exam, rheumatoid arthritis, osteoarthritis. Anyone wants to comment on this? How you differentiate when patient comes to you clinically? How you gonna differentiate?
So symmetry is very distinguishing, sir. Rheumatoid arthritis is symmetrical, osteoarthritis is asymmetrical.
So this is symmetrical. This is asymmetrical. This is one point. There are at least 10 points. This is one of them. Symmetrical means rheumatoid arthritis when patient present, you have bilateral symmetrical usually, both upper limb, both wrist joint, right? While in osteoarthritis is a degenerative disease, degenerative joint disease, isn't it? Yes or no? Right? Degenerative. So rheumatoid arthritis is symmetrical. Symmetrical means both the side, it is same, both wrist, both knee, both fingers, like that, both shoulders, both metacarpophalangeal, not metatarso, metacarpophalangeal. So this is one. What is the another differentiating point? What is the differentiating? You must know. You can't keep quiet. You must know.
The
It
joint
is not a very,
involvement.
yeah. So joint
Yes.
involvement. Which joint
Yes.
involvement?
In rheumatoid arthritis, it usually affects the proximal metacarpal joint, while in
Proximal
osteoarthritis,
metacarpal. Yes.
yes, in osteoarthritis, it affects the distal metacarpal joints and the big joints like knee and other big joints.
Fine, fair enough. This is second. Third one. Because this is one of the most pseudo gout, osteoarthritis, and rheumatoid arthritis is your homework. Read all four chapters today in detail, in depth. 100% 2-3 question comes from this. I'm just discussing all high yield points with you, right? Right. So you need to understand each and everything. Now let's get head to head comparison. Rheumatoid arthritis, osteoarthritis. So what is rheumatoid arthritis? So rheumatoid arthritis, as you know, female is more than male, right? So I can say 9 female and 1 male, rheumatoid arthritis. I'm talking about RN, right? This is this much of high. Here again, female is more, right? But the age, if you can see in epidemiology, more than 55. Very rarely osteoarthritis you can see in a young age patient, right? You cannot see much in young age patient, and here rheumatoid arthritis you can see in the young age patient as well, right? Especially in a female of 40s, right? You can see this is an autoimmune disease. This is a degenerative joint disease, right? So this is more in female. Almost 9 out of 10 female is female in rheumatoid arthritis. Here more female, but can be occur in male as well frequently. The risk factor, family history of rheumatoid arthritis. So when you are taking the history of the patient, you must ask. They may say, my mother has rheumatoid arthritis, blah, blah, this, that, sister has rheumatoid arthritis, right? So it's important. History of joint injury or trauma, right? One Osteoarthritis is an aging process. Obviously, it's an aging process. Age itself is the biggest risk factor. But on top of that, if you have a trauma, if you have injury, right, there may be a inflammation and obese patient. Why? Because he has to bear weight on the knee joint, and there is a wearing and tearing of the joint, and that is why you get more arthritis. So obesity is a risk factor. So whenever you are treating a patient of osteoarthritis and he is obese, try to tell them to reduce the weight, because this is one of the good treatment. Reducing the weight will have a reduce the problem on the joint. So this is rheumatoid arthritis. This is osteoarthritis. So we have seen what is the epidemiology. We have seen the risk factor. Now third, course of the disease, extremely important. Usually chronic course, right? Uh, and then if you don't treat it progressively, and it will going to do the advanced joint changes. This is absolutely chronic progressive course, right? So patient has a history of 5 years, 4 years, 6 years, right? So a common joint is a knee joint. Knee joint is the most common joint for osteoarthritis, and treatment is the TKR, total knee replacement, is the treatment in the end stage, right? Clinical feature extremely important. If you understand this, by knowing this, you can answer without doing any test. Constitutional symptoms are there. Fever, fatigue, which is not there. No constitutional symptoms. This is because of inflammatory, right? Autoimmune disease or some kind of this fever and fatigue and muscle things are there, which is absolutely not there. Morning stiffness more than 30 minutes. Absolutely differentiating point. Morning stiffness, right? And morning stiffness less than 30 minutes. So very few, right? So this is one differentiating point. So patient comes to you, female comes to you, 40 years of age. I have bilateral wrist joint pain. I have fever. I have muscle pain, right? I have stiffness when I wake up in the morning. I have a stiffness in both the wrist joint, which usually lasts for more than 30 minutes or 1 hour, right? Which is not the case in osteoarthritis, right? Because there is no inflammation much in the joint. It is degenerative disease. This is inflammation. So pain and stiffness may be relieved by activity. This is extremely important. So when patients say that I when I wake up at 10 o'clock, I have too much of pain, but pain and stiffness increases with the activity. This is increases with the activity, right? And relieved by the pain and stiffness may be relieved by uh, activity. Sorry, pain and stiffness may relieved by activity, and here it is increased. So patient 50, 60 years of male having osteoarthritis of the knee joint, right? Morning, the pain is little less, but as the day passes, joint uses, pain is increased, right? So pain increase with the activity here, pain reduce with the activity here. Intensity of the pain lasts more than 30 minutes in morning, which is less. This is again a very important differentiating point, right? And swollen and warm joint. This here usually no pain, no swollen or no warm joint. So osteoarthritis is in everybody's home. Your father, mother, probably 60, 65, 70, they may have osteoarthritis. So they won't have swollen joint. They may not have a warm joint. Joint is normal. There is no much. Only just symptoms here in osteoarthritis is the pain, which increases with the activity. Usually seen in the elderly people, and all blood tests are normal. This is the clue. All blood tests are normal. We'll see that, right? So this is the tips for you, right? What else? What else in osteoarthritis and this rheumatoid arthritis? So osteoarthritis and rheumatoid arthritis. First is rheumatoid arthritis. It is bilateral, symmetrical, usually asymmetrical. Only right or left knee joint is involved. Right or left. Here, right and left, they are bilateral, symmetrical, both involved same, right? Pattern, it is polyarthritis, not a one joint involved. As I told you, polyarthritis, predominantly wrist, metacarpophalangeal and proximal interphalangeal joint. Here, the biggest difference is the distal interphalangeal joint. Distal interphalangeal joint. Proximal interphalangeal joint. Rheumatoid arthritis is the proximal interphalangeal joint, and this is distal interphalangeal joint. Right? So this all clue will come in the exam as a part of your scenario. So you must know how you can think of, right? And what is the clue here? Spare distal interphalangeal joint. They rarely involved in rheumatoid arthritis. Spare means saved, not involved. Distal interphalangeal joints. And here, right, so distal interphalangeal joint. And last but not the least, right? there is a Bouchard nodule and Haberden nodule, respectively. So proximal interphalangeal joint, it is Boucher's nodule, and distal interphalangeal joint, it is Haberden nodule. So you must have seen some picture, right, with the nodule on the fingers, right, on the hand, right. So you go and see the picture, how the Bouchard and how the Haberden. So proximal interphalangeal joint, Bouchard nodule, and distal interphalangeal joint, Haberden. So proximal, it is seen in the rheumatoid arthritis, proximal interphalangeal joint, distal osteoarthritis. So if somebody asks you what kind of nodule seen in osteoarthritis, it is Haberden. What kind of nodule seen in the rheumatoid arthritis, it is a Boucher, right? And they usually spare the wrist. They usually spare the wrist. Very rarely osteoarthritis is seen in the wrist joint, which is common in rheumatoid arthritis, predominantly in wrist. So this is how bilateral, symmetrical, female, morning stiffness, right? Plus bilateral fever, associated symptoms, right? And proximal interphalangeal joint have this Bouchard nodule, positive rheumatoid arthritis factor. All more goes in favor of rheumatoid arthritis. So history is extremely important, right? And last but not the least, this comparison for this is osteoarthritis and rheumatoid arthritis. Right, so it's important. Third, RF factor. If I can, what is the most sensitive and specific test to diagnose RA? Most sensitive and most specific test to diagnose RA, rheumatoid arthritis.
Anti-CCP antibodies.
Excellent. Anti-CCP antibody. So screening is RA. You can do the RA, but RA test can be present in lot of conditions, right? And this is not present in all the conditions, right? So 70% of the patient may have RA, right? But this can be seen in other autoimmune or mixed connective tissue disorder. Most sensitive and specific, it is anti-CCP antibodies present in RA, which is absent in osteoarthritis, obviously, right? And this is a autoimmune disease. If you aspirate the synovial fluid, right? Neutrophils are increased, proteins are increased, right? Here the WBC is normal, it is not infective. This is non-inflammatory, so it is likely normal. All the aspirate things are normal, right? And here osteoarthritis and this joint space is narrowing. Obviously, joint space is narrowing both the condition, right? Here osteophytes are seen, subchondral sclerosis is seen, and subchondral bone cysts. Mug up these three things: osteophytes, subchondral sclerosis, and subchondral bone cysts, right? Sometimes they may give you the joint of knee joint. This is patella, and they will give you, right? There is a development of osteophyte, as well as they can see a subchondral sclerosis, right? And there is a formation of cyst as well. So they may give you the X-ray and try to find out what kind of X-ray is this. Is it RA, osteoarthritis, rheumatoid arthritis, gout, or pseudo gout? So don't get confused. These are the word, right? So look at the radiology of knee joint and things. A lot of things I have to discuss, but considering time, not going in much detail, just high view points, right? So this is the differentiating point between this and this, right? Can anyone tell me, last question, what happens to calcium in osteoarthritis? What happens to phosphorus? What happens to alkaline phosphatase? What happens to vitamin D? And what happens to ESR in osteoarthritis? Anyone? If you have a patient, they are asking what is increase and what is decrease in osteoarthritis from these 5 labs. Give your answer.
Everything will be normal, sir.
Everything is normal. Why alkaline phosphate will not get increased?
Sir, I think everything is low except ESR, which is high.
Okay, so do you think that in osteoarthritis everything is low, right? This all low except ESR is high. That is what you think?
Yes, sir.
So what do you think? Why ESR is high? Why alkaline phosphate is low? Why calcium is low in osteoarthritis? Don't get confused between
No.
osteoporosis and osteoarthritis. We are talking about osteoarthritis, not talking about osteoporosis or osteomalacia. That is the next question. Yes, now tell me. You must know that you have a patient of osteoarthritis, 70 years of male gentleman presented with, this is classical presentation. Remember what I'm describing. 60 plus patient, male or female, presented with right knee pain, which is increasing progressively over a daytime. And by the end of the day, it gets worse. Unilateral pain and swelling, difficult walking, right? This is classical osteoarthritis, right? So what do you think? What electrolyte or what this minerals, the calcium, phosphorus, alkaline phosphate, vitamin D, or this happens? We never thought of that. No, we just keep reading, but we don't know how, what to do. Yes, Madhusa, any comment? Nasreen. These all questions in
Calcium will
various
be low.
exam. Calcium will be
So
low.
Phosphor
That
will
is
be
wrong.
high.
calcium, calcium
Calcium will,
phosphate and
yes, go ahead. Try to stretch your neurons. Get out of the monotonous preparation. Yes, go ahead.
sir, osteoarthritis is non-inflammatory, so ESR will be normal. It should not be raised.
ESR will be normal. Okay, fine. So ESR will be
Yes,
normal. So
yes.
what happens to all other things? Calcium, phosphorus,
The calcium
alkaline
and
phosphate.
calcium, phosphate, and vitamin D. This is all related to osteoporosis. In osteoarthritis, it's a degenerative disease, so it will not be related to calcium and vitamin D. It will be normal.
Right. So everything would be normal by your sense or your experience in a clinical setup. Right?
Alkaline phosphate might raised because of degeneration of the bone in osteoarthritis.
This is the second question, but let me show you this picture. It's important, right? So rather, let me discuss the second question, then we'll discuss. So concluding our talk, right? This patient has a suffering from gout. You must know pseudo gout, septic arthritis, reactive arthritis, and osteoarthritis. So there are 15 MCQs in this, right? So what you need to know, right? So we solved 15 questions. How you diagnose, how you investigate, and how you treat gout. And same for all five. So five multiplied by three, right? Five condition and three things you must know for each: diagnosis, investigation, treatment. Diagnosis, investigation, treatment. So 15 question we solved so far. If you don't know, you go and read it once again. How you diagnose, investigate, treat. How you diagnose, investigate, treat. How you diagnose, investigate, treat. How you diagnose, investigate, and treat. We need three answer for each and every MCQ, right? So today probably we are going to solve 50 to 90 MCQ today in our lecture, right? So go and read it. If you feel that I'm not good in septic arthritis, right? So how you differentiate why it is not septic arthritis? Let's discuss this. So septic arthritis, right? So there is no history of major trauma, no history of fever, no history of increased WBC count, no history of this patient, right? No history of joint aspirate material, right? Which is full of pus. Joint is full of pus in septic arthritis. When joint is septicemia in the joint, say for example in the joint, there is a septicemia. So when you aspirate, you have a pus, right? You have a pus. So this doesn't looks like from any angle this, right? And this is not osteoarthritis as well, right? In osteoarthritis, urate level is not increased. Point against it, right? There won't be any metatarsophalangeal joint, right? It is commonly seen in the large joint, big joint, right? So that is also important. There is no other history, how it increase, how it decrease, blah, blah. So these all are the clue for you to understand. Our job is not just to mug up the answer. They may ask you something else. But if you know the basic and concept, then you can answer any questions with the arthritis. Second question, little related, but extremely important. The patient is presented with the body ache and pains with anorexia. She is menopausal for the last 2 years. Lab shows low vitamin D, low serum calcium, low phosphate, low 24 hours urine calcium, and increased alkaline phosphate. X-ray hip shows a fracture on the right side. What's your diagnosis? Osteoporosis, osteomalacia, Paget disease of bone, osteogenesis imperfecta, chronic renal failure. Take your time. You see the scenario. If you read the scenario well, 90% of the questions you can answer as easily if you cultivate the practice of reading it properly. What's your answer in the chat box? We have a lot of things in chat box. So ESRM, alkaline phosphate, is not increased in osteoarthritis. Dr. Lalita, just for the knowledge, right? So in osteoarthritis, everything is normal. We'll see one by one. Yes, I want to post the answer each and everybody. There are more than 30 doctors. Answer is only one. You apply, na? What do you think? What it could be? Paget disease is what? Blah blah. Yes, Susan. Any comment, Dr. Susan? Yes, Dr. MD Shadab. Any comment?
Let's say osteoporosis.
Okay. So osteoporosis. Your comment is osteoporosis. So now tell me, sir, what point favors the osteoporosis in this patient? Go one by one. Scenario is in front of you. So tell me, sir, this is the point favoring the osteoporosis. Tell me.
Menopause.
Siege mono
One minute.
also says menopause for 2 years. So there is low vitamin D deficiency there and low calcium there. It's
So let me tell you, right? So this patient is presented with the body ache. Patient presented with the anorexia. She is a menopausal woman, so must be around 50 plus something, right? Now, what they are showing, vitamin D is low, calcium low, phosphorus low, right? They low 24 hours uric calcium and increase the things only increase alkaline phosphate. So, what do you think? This condition favors what? You have 5 options. What do you think? What fits the most? And we'll see what see in other conditions as well. But first of all, do you think in osteoporosis, vitamin D, calcium, and phosphorus low, sir? Dr. Shada?
yes, sir. Sir, we can give sir calcium and sir vitamin D, sir.
No, we can give is not the answer. Sorry. I mean, don't take it otherwise. I'm just trying to make it more understandable way and debate. What is your diagnosis? So do you think in osteoporosis, all these things will happen? What it is written?
Yes, sir. Yes, sir.
Yes or
Yes,
no?
sir. It's osteoporosis.
Okay.
Yes, sir.
Fine. Fair enough. Second thing, what is the definition of osteoporosis and what is definition of osteomalacia? What's the
Sir,
impression in your mind?
sir, osteoporosis, this bone density is very less, sir. It's
Okay,
very
great.
weak bone, fragile.
Wonderful. And what is in osteomalacia?
Osteomalacia, sir.
And so if you don't know, well, that's fine. Okay, it's a learning platform, so nothing to worry. You go and read it both. Head-to-head
In
comparison. When you do head-to-head
osteomalacia,
comparison.
the bones become softer, sir. In
Okay.
osteoporosis, bones doesn't become softer. Only
Okay,
the
fine. So,
density reduces because of hormonal changes in the woman.
fine. So would you like to define how you define osteoporosis and how you define osteomalacia? If I tell you, please define osteoporosis, how you define? Anyone, I mean, you means any open. Anyone wants to define osteoporosis, they can define. Because without clarity in the mind, you may not probably able to answer in exam. We have clarity, but you need to have more clarity. Yes, Dr. Sangeeta, any comment? Dr. Zara Baba.
Sir, with the help of bone density in
T
test.
scores. Yes, sir. T scores less than or equal to minus 2.5 is osteoporosis.
Right. No, so that is a investigation. That is the investigation. So what's the basic concept in the mind of the osteoporosis? If somebody tells you this gentleman is suffering from osteoporosis, what's in your mind? See,
Calcium is less, sir.
you are going to confirm by doing some various tests. One of them is the DEXA scan, right? For the osteoporosis, but that is the
Yes,
investigational part. So what's the general impression in mind? That is what I'm saying, right? If
sir.
somebody say, yes,
Calcium is less in that patient, sir, because of which there is reduced calcium phosphate and bone density, and there will
fair
be
enough.
increased risk
Fair
of
enough.
cancer.
Well, let's see. Dr. Sandhya Pawar, would you like to make any comment on this? Fair enough. So let's see what the literature is showing, right? So this chart is absolutely self-explanatory. We'll go one by one chart and then we'll see, right? So first of all, make some clarity in your mind. What is osteomalacia and what is osteoporosis? And third, don't get confused with the third term, that is osteoarthritis. That is the third term, osteoarthritis. Just we have just seen now, osteoarthritis is different, osteomalacia is different, osteoporosis is different, osteogenesis imperfecta is also different. Right? We'll see one by one because all four question in exam, any exam. So osteoporosis is a reduction of the bone mineral density. You remember as a DMD. So reduction of the bone mineral density. And here osteomalacia is a demineralization of the bone, right? This is osteoporosis is an elderly condition. It is seen in elderly, usually 65. Age is extremely important in all patients, believe me. So this cannot be seen in a young patient, right? 30 years of male, I have not seen with osteoporosis so far, right? Of my 20, 30, 25 years of clinical practice, except they are immunocompromised on heavy steroid, right? Or bad underlying bones. They, in that case, it's happen, right? But usually not in young healthy. This is the adult, right? Third thing is what? The cause. The cause. What is the cause of osteoporosis? So osteoporosis is deficiency in the calcium and the phosphorus, right? Some endocrinal disorder and alcohol drinking can make you osteoporotic. What's the here? Here, no calcium, no phosphorus, no drug, no endocrine. The main reason is vitamin D deficiency. Vitamin D deficiency. If it is happen in children, it is called as a ricket, isn't it? Yes or no? At least tell me yes or no.
Yes, sir.
Ricket, right? And treatment is what? You have deficiency of vitamin, so you just give the treatment with vitamin D. That's it. This is what the treatment is for osteomalacia. Osteoporosis is a bit different thing. It is not just the vitamin D supplementation. It is healthy lifestyle, calcium, right? Deficiency of calcium, so you need to supplement the calcium, right? And other things, and trying to rule out the underlying things as well, right? So this is what the thing is. 1 second, please hold on.
What is the reason of osteomalacia, sir? Like, demineralization of bones happen in young?
I will get back to you. I have one emergency call. I'll answer you 1 minute. Yeah, sorry. So this is what the thing is, right? So you need to have little more clarity on this, right? You were asking me some questions. Sorry, I got a call from emergency room. Yes, still now you ask me. Sorry, you were asking me
It's
something
like
important.
demineralization of bones happen only purely because of vitamin D deficiency in those
Yes,
adults.
absolutely, absolutely,
Okay.
and children's as well. Children's we name it as a ricket. That's it, right? And
It can
here what
happen to
happens?
anyone in that way.
Yes, yes, it can happen to anyone. That's correct. And second thing is here, if you can see here, right, the here you can see the classical X-rays, which I did not have it right away. So you can also go and see the how X-ray sees in both the things. Right here, the curving of the back. and which increases the risk of fracture. Osteoporosis. They are fragile bone. All right. So more risk of fracture with osteoporosis than osteomalacia. Right. So treatment, you go and read it once again. And now let's get back to the chart. Let's get back to the chart. Right. I want you to understand this chart. 100 questions we can answer in this one chart. So those who have something completely, so this is osteoporosis, malacia, which is osteoporosis. Once again, it is osteoporosis more common than osteomalacia because nowadays vitamin D fortification and lots of awareness, people are taking vitamin D nicely. So they may not get develop this osteomalacia. As we know, this is because of vitamin D deficiency, right? Gender, female is more common than male, as here male female is usually common. Fracture of the weight bearing areas, mainly spine, hip and wrist is more common, right? Here fracture is very less common, so you won't usually get pain. Osteoporosis usually painless until and unless they get fracture, huh? Otherwise they are painless. And this is a prominent feature. Osteomalacia, it is a very prominent feature, right? So it is differentiating point. Muscle strength is normal. Here there is nothing to do with the muscle. Here the weakness is there because of vitamin D deficiency. There is a pain and weakness, pain and weakness. Pain is a prominent feature, weakness is also there, which is not there. Pain is usually not there in osteoporosis. Muscle uh, weakness is not there, right? And we will see the chart. So this is what the head-to-head comparison. Let's get back to this chart, Osteoporosis. So those who answered me all low, it is not all low. Calcium normal, phosphorus normal, alkaline phosphate normal. For your knowledge, so osteoporosis of the bone or osteoporosis, you get everything calcium, phosphorus, alkaline phosphate normal. Osteomalacia, as per this scenario, what was this scenario? Vitamin D low, calcium low, phosphorus low, and alkaline phosphate high. Isn't it? Yes or no? Would you like me to go back to this scenario? This is the scenario. You can see here, vitamin D low, calcium low, phosphorus low, and alkaline phosphate high. This is the scenario. So answer is osteomalacia here, osteomalacia, right? So this is the answer for the things. But there are more 10 questions attached with this in exam. So answer here, osteomalacia, low calcium, low phosphorus, high alkaline phosphate. What you see in the Paget disease, right? So how you differentiate Paget disease? In Paget disease, just remember only alkaline phosphate is high, the rest of the things are normal. So how you differentiate osteoporosis to Paget disease? Osteoporosis all low, all normal. Paget disease all normal except alkaline phosphate, right? How you differentiate osteomalacia from Paget? Here calcium and phosphorus low. Here calcium and phosphorus is normal. Are you getting me? At least tell me yes or no, please.
Yes, sir.
Yes.
Yes.
Right? So these three things are done. These three things are done. So there is no confusion. If everything is normal, osteoporosis. Only alkaline phosphate increase, osteomalacia. If alkaline phosphate increase, but other calcium phosphorus normal, Paget disease. Multiple myeloma is a disease of plasma cell disorder. Plasma cell. When plasma cell is more than 10%, monoclonal plasma cell more than 10% in blood or bone marrow, it is called as a multiple myeloma. And when multiple myeloma, there is a crab fracture. You have a lot of revision in a one question. Crab means calcium hypercalcemia. So see, hypercalcemia, calcium is high. Renal means renal insufficiency. A means anemia. B means bony destruction. Osteolytic punched out lesion. So bone gets fragile and easy to get the fracture. So this is the crab criteria in multiple myeloma. So calcium, C amongst crab, C is the calcium. So hypercalcemia. So calcium is high. Phosphorus is also high, usually high, could be normal. See here, normal, alkaline phosphate normal. So whenever you have any doubt in your mind, right, you just the calcium, phosphorus, and alkaline phosphate for any bony disease, right, or any bone disease, by which this table you can differentiate a lot of things, right? So here the calcium is high or hypercalcemia. Bone metastasis, when the bone is met, secondary to bone, lung cancer spreads to bone, breast cancer spreads to bone, right? Or multiple myeloma spreads to bone, or any other renal cell carcinoma. These are the common cancers which I'm telling you in our day-to-day practice. Everything is high. So I routinely do in all my patients every day. I'm seeing every day at least 50, 60, 70 oncology patient, and there are a lot of bone metastasis. So I just, for my academic purpose, I send them calcium, phosphorus, alkaline phosphate. I usually see all high. So primarily lung cancer, but spread to bone, everything is high. Everything is high, is not in any condition except bone metastasis. Except, you can see, you can check all the chart where all three are not, not, not any condition except bone metastasis, right? So calcium, phosphorus, and alkaline phosphate high, right? Renal failure, calcium is lost, so calcium is low, right? Like osteomalacia, calcium is low here, right? But you can see phosphorus is low in osteomalacia, here high. Here also, here renal failure, alkaline phosphatase is high. So you can see the similar condition, right? Osteomalacia and chronic renal failure by and large looks like little same. Why? Because in osteomalacia, calcium is low. In renal failure, calcium is low, right? In osteomalacia, alkaline phosphatase is high. It could be high, but what is the difference? Phosphorus is low, phosphorus is high. So this is a very important table for you guys, right? For answering lots of questions related with the bone metastasis, related with this, blah, blah, right? So hyperthyroidism. So nothing, I mean, you don't need to mug up. You need to understand the things, right? So those who answer osteoporosis as all high or all low, it's wrong. Osteoporosis, right? It's an aging process. Osteoporosis happen at the elderly people, right? So if you do calcium, phosphorus, alkaline phosphate, they are usually normal. Is that clear to everyone? Yes or
Yes, sir.
no? Wonderful.
Sir, in osteoarthritis, sir, also everything will be normal.
Osteoarthritis is usually everything is not. Osteoarthritis, again, there is a degenerative disease. So degenerative disease, you won't get anything, right?
Thank you, sir.
ESR is also normal and LDH is also normal, for your kind knowledge. It's osteoarthritis. This is Paget disease in general, just for your knowledge. So Paget disease is what you probably you know, you don't know, but quick, because Paget disease extremely good amount of question comes. So Paget disease of the bone is also, what's the pathogenesis? Increased bone remodeling, right? So bone remodeling, increased osteoclastic and osteoblastic activity. Diagnosis: isolated elevation of alkaline phosphatase with normal calcium and phosphorus. We already seen it, right? We already seen it. Go back and check it. Paget disease. Go and check it, right? So this is correct answer, right? Paget disease, remodeling, calcium normal, phosphorus normal. What increase is the alkaline phosphate. That's it. This is Paget disease. So this is Paget disease. This is Paget disease. So alkaline phosphate elevated with normal calcium, phosphorus, right? And there is a deformities. You can see treatment is what is important in Paget disease. If they ask you what is the treatment of Paget disease, including in Paget disease is bisphosphonate. Can anyone tell me, while giving the bisphosphonate, what things you will keep in mind before giving the bisphosphonate? Bisphosphonate, this is important practical point. If you are giving this patient a bisphosphonate, you are patient of Paget disease, you confirm, right? And there is alkaline phosphatase is increased, there is a remodeling, classical osteoblastic plastic activity. You want to treat this person, you have given the bisphosphonate. Bisphosphonate. What test you will do before giving the bisphosphonate? And anyone else?
So,
Anyone?
so bisphosphonate usually limit the loss of bone density.
Right.
Sir, it causes GERD more, esophageal problems, gastric acidity.
Possible. So the test you would like to do is the EGFR, estimated glomerular filtration rate. With bad kidney, less than 30 to 45 EGFR, you are not supposed to give this bisphosphonate. It's a renal toxic. So most important clinical things what we do, right? I'm giving bisphosphonate every day, especially to the bone metastasis patient. So indication of bisphosphonate is not just Paget disease. It's a Paget disease you can give. You gave in the osteoporosis patient. You can give. Osteoarthritis patient. You can give. The theory is that the mechanism of action is not known, but it strengthens the bone and reduces the hypercalcemia. So we use in multiple myeloma, use in any bone metastasis from any other primary. We use it in Paget disease as well. right? So this is Paget disease. What is osteogenesis imperfecta? Anyone have any idea? Osteogenesis imperfecta. We have heard hundreds of times the name osteogenesis imperfecta. So what do you mean by osteogenesis imperfecta? Anyone, open for all. Osteogenesis imperfecta means what?
Sir, it is also called as brittle bone disease, sir. That collagen 1 formation is not properly formed. That's why sclera, osteosclerosis can be seen in children, sir. It's genetically genetical disease.
Wonderful. So I'm at least glad with your explanation, and this is what the osteogenesis imperfecta. Many times recently they asked the exam in the question regarding the osteogenesis imperfecta. So I'm just trying to give you a little quick idea what it is, so you at least know the idea, so you won't feel surprised in the exam. Osteogenesis imperfecta prevalence 1 is 110,000 to 20,000, male, female equal classification. Right? You don't need to be that into the logistic. You just need to know the short stretcher, right? Facial appearance, deafness is important. So somebody bony problem with deafness, think of osteogenesis imperfecta. Bony problem with the blue sclera, think of osteogenesis imperfecta. With scoliosis in a children, think of osteogenesis imperfecta, right? So these are the key high yield points for the osteogenesis imperfecta, right? So there are lots of genetic genotype and phenotype problem, but for GP you don't need to go much in detail. So that's it. So this is the osteoporosis. So this is the answer of our question, where vitamin D, calcium, phosphorus is low, alkaline phosphate is high. So this is osteomalacia. The most common cause of osteomalacia is vitamin D deficiency, as we see. Normally, vitamin D is derived from the sun exposure. So even probably you and me are more prone to osteomalacia because we are not exposed to sunlight. We have seen even my own vitamin D is very low, honestly speaking. So we need to have some little sunlight, right? And try to modify the diet, which is containing good in vitamin D, right? Probably the milk is the good source and other natural antioxidant, and try to expose yourself in the sun at least for 2 to 5 minutes, preferably before 8 a.m. This is what some literatures are showing, right? After that, avoid between 12 to 5 because there is a high ultraviolet radiation. So before 8, if you are living in a country where the sun is good, try to little have a walk and try to expose your skin with the sun. That helps you to prevent from the vitamin D deficiency. And that's it. Vitamin D and calcium you can supplement. So that's it. This is what the thing is. So let's jump to the next question, right? Let's jump to the next question. This is the picture. This is the picture. Recently asked exam question. This is the, let me tell you the little story of this. Little story of this. 5 years of boy, male, presented with the neck swelling, African descent, presented with the neck swelling. Right here in the neck, there is a swelling, right, which is looks like a enlarged lymph node cut, excisional biopsy done for the enlarged lymph node, and excisional biopsy of the lymph node shows this appearance, right? So, and it looks like this picture, right? So, what it could be the diagnosis? Follicular lymphoma, diffuse large B-cell lymphoma, Burkitt's lymphoma, CNS lymphoma means primary CNS lymphoma, and gastrointestinal stromal tumor. So, what it could be? Probably it's a credit question. No? Every time you can't expect the lollipop simple question because this DHA hard emerge is getting tougher now. They're keep putting little tricky questions. Yes, yes. I want everyone to post the answer, not just 2 or 3 candidates. I have only 3 answers in front of me. We are 35 people. Answer is only 3, just 10%. Comment. Yes, anyone? Yes, Dr. Bhavya. What do you think? What it could be? Dr. Bhavya, any comment? Yes, Dr. Sandhya, what's your comment? How you define? You can unmute your mic. Yes, anyone? Yes, what it could be?
Burkitt's
Sorry,
lymphoma.
Burkitt's lymphoma. So tell me something about Burkitt's lymphoma.
It's a
Whatever the
type of
knowledge, whatever the
non-Hodgkin's.
it's
Epstein-Barr
not
virus infection
okay. So what is
associated with
the okay? Fine. So what is the age? In which age it is seen? Associated with what? How is the commonest presentation? How you diagnose? You tell one by one. Fine, no problem. Yeah, go ahead. Yeah, go ahead. Anyone?
Usually present as painless swellings, lymph node swellings.
Okay. Usually present as a painless lymph node swelling. In which part of the body? Usually.
Neck,
Neck.
cervical
Usually neck. Yeah,
normally
cervical or neck region. And second more common is a GI. GI. Recently, I had one patient we are treating and giving chemotherapy. He presented with the intestinal mass. Eventually turned into be Burkitt lymphoma. So neck is common, but GI is also common. Anyway, that's it. So this is the what the thing is. So what you can see in the picture? What you can see? What the name of this picture?
starry sky
starry sky
appearance.
appearance.
It is already written starry sky appearance. So starry sky appearance is the diagnostic of Burkitt's lymphoma, right? So this is what the thing is. So now let's go little further, right? So this is the Burkitt's lymphoma. So let me give you the literature. So you will learn more, right? So this is the Burkitt's lymphoma. One second. Yes. So Burkitt's lymphoma. So what is Burkitt lymphoma? So Burkitt lymphoma is a high grade, aggressive high grade B cell lymphoma. It's not a T cell lymphoma. In lymphoma, there are two B cell and T cell. I'll give you the accurate comparison. Most commonly in the children, right? Associated with the translocation in 814. High yield question in exam. High yield question. Mug up this high yield. So what are the 2 point? It is seen in the children, Burkitt lymphoma. In scenario, children, right? It is high grade lymphoma. B cell origin, translocation in chromosomal analysis is translocation T814, right, in 75% of the cases. Which virus is associated, as rightly told by Dr. EBV, Epstein-Barr virus, EBV, all right? And in adult, also association with HIV as well. So if you have a pediatric patient, probably more goes in favor of EBV or Epstein-Barr virus. And in adult patient, when you diagnose this Burkitt's lymphoma, probably attached with the, associated with the HIV as well. So this is general understanding, right? A starry sky pattern is a distinctive histology, starry sky. So this is all starry sky. When you stare at the sky, starry sky. This is all starry sky appearance. White, starry sky. This is classical picture they will give in the exam. So starry sky pattern is a distinctive histology feature that can be seen in lymph node biopsy sections and is specific to Burkitt's lymphoma, right? So just keep this image in the mind, right? So that will help you for the exam point of view, all right?
Sir, this is
Uh,
a type of non-Hodgkin lymphoma, na, sir?
yes, it is a type of non-Hodgkin's lymphoma. I will come to the important high yield points right away. So now let's get back to the basics of lymphoma. Hundreds of questions they ask for the lymphoma. Head-to-head comparison, Hodgkin's lymphoma, non-Hodgkin's lymphoma. Can anyone tell me what is the key difference between Hodgkin's lymphoma and non-Hodgkin's lymphoma? The only key difference.
Reed-Sternberg cell is present in
Yes, so
Hodgkin's lymphoma.
Reed-Sternberg cell. So what is Reed-Sternberg cell? These are the two gentlemen. One is Mr. Reed and one is Sternberg. They first time seen this. So this is the Reed-Sternberg cell, mononuclear identical cell. This is classical case called as RS cells. Reed-Sternberg cells are present, right? It is a Hodgkin's lymphoma. If the Reed-Sternberg cells are absent, it is non-Hodgkin's lymphoma. So this is the most important basic classification I'm going to tell you, right? And it all high yield exam oriented. And it is also called as all eye. Have you seen the word all? So this is called all eye. Have you seen? Yes or no? At least tell me yes or no. All eye, right? So this is the Hodgkin's lymphoma is all eye appearance. When you cut the lymph node, when you cut the tissue, you can see exactly the identical hundreds of Reed-Sternberg cell in your lymph node biopsy or some other tissues or bone marrow or wherever the RS cells are present, you see this thing. So presence of RS cells is Hodgkin's lymphoma. Absence of RS cells is non-Hodgkin's lymphoma. Is that clear to everyone? Yes or no? At least tell me yes or no. Yes or no?
Yes.
In Hodgkin's lymphoma, classification of Hodgkin's lymphoma or types, you can say Hodgkin's lymphoma, how classified? Hodgkin's lymphoma is two, classical Hodgkin's lymphoma and non-classical Hodgkin's lymphoma. Can anyone tell me how you differentiate classical from non-classical? As I told you, RS cells is Hodgkin's lymphoma. RS cells absent, Reed-Sternberg. How the Reed-Sternberg look like? This is all eye. This is the RS cell exactly looks under the microscope. How the classification of classical versus non-classical? Aisha, any comment? How you define Dr. Ishrat? Any comment? So presence of CD15 and CD13. If it is present, it is classical Hodgkin's lymphoma. If it is absent, it is non-classical. Very important. Second point. Each and every point is a high yield forever. Subtype. What are the four subtype of Hodgkin's lymphoma? Right? Nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte poor, right? These are the four common this subtype of Hodgkin's lymphoma. So if you cut the lymph node, right, you may have this four histology. I'm not going in much detail, but you must know because of the exam. So no, if they ask you which subtype is the most common, so nodular sclerosis is the most common. Mixed cellularity is second most common, which has the best prognosis, lymphocyte rich, best prognosis. Lymphocyte depleted, poor prognosis or worse prognosis. This is what they ask in exam. So how many questions? What is Reed-Sternberg cell? How you differentiate Hodgkin's from non-Hodgkin's? What is classical Hodgkin's lymphoma? This, what is non-classical? What are the subtype of this? What is the most common? What is best prognosis? What is worst prognosis? So almost 8-10 questions we covered in this slide, right? So this is subtype, right? And treatment, you must know the treatment as well. Here the treatment is ABVD. Can anyone tell me what is ABVD?
Adriamycin.
Okay, so let me write A for adriamycin, B for
Bleomycin.
B for bleomycin,
V for vinblastine.
V for vinblastine, and D for
Dacarbazine.
Are you in the hematology ward?
No, sir.
Wonderful. I'm very glad.
Your videos were very good and clear, sir, to remember.
Wonderful. So adriamycin, bleomycin, vinblastine, and dacarbazine. So adriamycin is a drug, anthracycline drug, and here the list of the tests. Before giving this drug, what tests are important? Adriamycin is cardiotoxic, so baseline 2D echo for the ejection fraction is mandatory before starting echo. These all are the exactly high yield point. You can take a picture of this as well. Bleomycin is cause the pulmonary fibrosis. So before starting this, pulmonary function test is mandatory. Vincristine, vinblastine is neurotoxic drug. So now conduction study we can use, and this is also sometimes this pulmonary function test also here important. So these are the drug internationally named as the ABVD regimen for Hodgkin's lymphoma, right? So this is extremely high yield point, right? Same way if we comes here for the non-Hodgkin's lymphoma, right? Non-Hodgkin's lymphoma, absence of the Reed-Sternberg cell, so you cannot see the all eye or mononuclear identical cells under the lymph node biopsy. Non-Hodgkin's lymphoma has a more than 50 subtype, more than 50 subtype. Let me tell you, right? This again, Hodgkin's lymphoma is usually B cell type, right? And this non-Hodgkin's lymphoma is a B cell and T cell, B cell and T cell. So it is called T cell lymphoma. This is called B cell lymphoma. The most indolent one, follicular lymphoma, indolent or slow progressing, indolent, less dangerous, slow progressing. Diffuse large B cell lymphoma is a aggressive lymphoma. And Burkitt's lymphoma, very aggressive lymphoma, one of the most fatal lymphoma if you don't treat, very aggressive. So this is what we see in the literature, right? Burkitt's lymphoma seen in the children, 814 translocation in more than 75%, very aggressive and originate from the B cell. Am I right? Yes or no? At least tell me yes or no.
Yes,
Right?
sir.
So same way, the T cell, if they originate from the B cell, it is B cell origin. If it is T cell, so T cell, so peripheral cutaneous T cell lymphoma, or another name I think is a Sézary syndrome, right? Or cutaneous lymphoma, right? And T cell lymphoblastic lymphoma, it's the most aggressive form. Just for your knowledge, right? We are treating daily all this. Hodgkin's, non-Hodgkin's is our oncologist everyday job, but you need to know because they ask in that. So this is what the thing is. So most highly, this aggressive is a Burkitt's lymphoma, starry sky appearance, as you've seen, right? This appearance is a starry sky, so don't miss out in the exam what is starry sky. So they may sometimes give you the scenario, they may sometimes give you the slide, they may sometimes give you the this scenario, so you can at least know, right, what it is going on. And this is what the again histology, if somebody is interested, Reed-Sternberg cell. So as I told you, how the Reed-Sternberg cell looks like under the microscope, exactly. So you can see the identical all eye, identical all eye. This is this all identical. You can see this is a Reed-Sternberg cell. So Mr. Reed and Mr. Sternberg, these are two gentlemen who did this first time. This is, you can go and read the detailed Wikipedia history of Reed and Sternberg. But this is how it evolves. Otherwise, what is Reed Sternberg? So Reed Sternberg is nothing miracle or magic. It's a two gentlemen who seen it first time. So name given as a Reed Sternberg cell. It is identical all. Follicular lymphoma, it is one of the most indolent lymphoma type of non-Hodgkin's lymphoma. Indolent lymphoma arises from the B cell. Diffuse large B cell, the name itself suggests. So diffuse large cell is a type of NHL, non-Hodgkin's lymphoma. Aggressive lymphoma, B cell origin, right? And Burkitt's lymphoma, one of the starry sky. You can see starry sky, white background, starry sky, right? So this is again a B cell lymphoma, one of the most aggressive lymphoma, type of non-Hodgkin's lymphoma. Treatment. Treatment chemotherapy, treatment chemotherapy, treatment chemotherapy, Hodgkin's lymphoma treatment chemotherapy. So standard of care or treatment is chemotherapy, right? So as we've seen head-to-head comparison here, right? The ABVD was treatment here, right? So I deleted, but the ABVD was treatment here. What is the treatment of non-Hodgkin's lymphoma in general? The commonest regimen for non-Hodgkin's lymphoma, if I can say, diffuse large B-cell lymphoma, what is the treatment of choice? If they ask you in the exam, you have a patient of non-Hodgkin's lymphoma, turn it to be diffuse large B-cell lymphoma, R-CHOP is the treatment. R-CHOP is the treatment. R-CHOP is the treatment. In Hodgkin's lymphoma, ABVD was treatment. Adriamycin, bleomycin, vinblastine, dacarbazine. Here the R-CHOP, right? This is for Hodgkin's lymphoma. This is for non-Hodgkin's lymphoma. R stands for rituximab. Rituximab. Anyone heard of this rituximab? It is anti-CD20 antibody, monoclonal. It is developed in the lab. So this is excellent. It changed the prognosis. So rituximab, cyclophosphamide, right? Doxorubicin, oncovin, or another name is vincristine. Here, don't get confused. Here, vinblastine. Here, vincristine. Don't get confused. Vincristine. Is that clear? Yes or no? And P stands for prednisolone. That is steroid. Is that clear to everyone? Yes or no? At least tell me yes or
Yes.
no. Right. So again, doxorubicin, you need to do 2D echo, right? Rituximab, you need to do hepatitis B and hepatitis C, because when you give the rituximab, there is an immune reconstitution and chances of reactivation of hepatitis B or hepatitis C. So this is very important credit questions, keep in mind. So that is what all about the lymphoma in general, the basic various questions they may ask you in exam, how you diagnose, how you investigate, how you treat, blah, blah. Right. So last couple of questions, let's see. Primary Sjogren syndrome, which antibodies detected? Anti-dsDNA, anti-GP210, anti-histone antibody, anti-Jo1, anti-LISSB antibodies. Take your own time. I want to know what all 5 antibodies present in which condition. There's all several questions. Yes. Yes, Safa. What's your comment? Yes, Dr. Safa Aisha. What's your comment?
Sir, here option D is the answer, sir.
In France. Okay. So now tell me, Dr. Safa, anti-dsDNA is seen in what?
So anti-dsDNA is mostly seen in SLE, sir.
Okay. So SL. Fine. Anti-GP210 is seen in what? So we need to know.
I don't know, sir. Anti-GP210. I don't have much
So
idea.
answer is pending. Where the anti-histone antibody is seen?
Sir.
Sorry?
Sir, antihistone is drug-induced SLE.
Biliary
We see
cholangitis.
if it
So
is
one is
SLE,
the
is drug-induced.
drug-induced SLE. And somebody also
Yes, sir.
told cholangitis, right?
No, sir. GP210.
GP210 is a cholangitis. Okay, GP210 is a cholangitis. Fair enough. We'll see the all. Don't worry. Anti-Jo1 seen in what?
Polymyositis. Polymyositis, sir.
Polymyositis. Okay. And anti-LISSB all?
Primary Sjogren syndrome.
Primary Sjogren. Now, can anyone define what is the Sjogren? How you define the way we define osteoporosis and osteomalacia? How you define the Sjogren? What is the definition of Sjogren? What is the things in your mind about Sjogren? What exactly happened in the Sjogren?
The dry eyes, dry mouth, because secretions are not there, is classical of Sjogren, sir.
Okay, so dry eye and dry mouth. Why dry eye and dry mouth happens? Why not other things are dry and mouth?
Parotid
Or,
gland and lacrimal gland secretion is deficient.
okay, great. And that deficient is because of what?
Anti
Autoimmune.
autoimmune destruction.
Antibodies
Autoimmune.
acting against them.
Wonderful. So antibodies acting against them. So which antibody? This anti-lion SSB, right? That antibody develops that makes them the jogger, right? So what is the treatment of jogger? If you have this patient who has anti-lion SSB antibody, how you treat?
Symptomatic would be
Steroids.
with drops and artificial saliva.
Saliva.
But
Steroids and again
the
rituximab.
any anti autoimmune would be steroid would be the main treatment.
Steroid would be the main treatment. Okay.
Or it also goes with HCQS and disease modifying drugs also can be an option.
Okay. Any comment from the audience?
Disease modifying drugs only, sir, at last. First starting with steroids.
If I can ask you the one line question, what is the best treatment for Sjogren syndrome? No option. Answer. One drug. Answer the one drug.
If steroid is the
No drug.
option, if steroid is the option, steroid only, sir.
If steroid is not in the option, then
HCQS?
Pilocarpine.
yes. So hydroxychloroquine, HCQ. Somebody told HCQ. So hydroxychloroquine is one drug and another is the methotrexate. Right. So just remember this too. If somebody asks you what is the treatment of choice for Sjogren, right? So treatment of choice is HCQ. HCQ is primarily meant to treat the malaria. Primary drug invented for malaria. All right. Used in Sjogren's as well. One is HCQ. The name is hydroxychloroquine. Quinine, chloroquine is all malaria. Right. So this is wonder drug for Sjogren. And second is a methotrexate, MTX, methotrexate. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Now let's
Methotrexate with
jump.
folic acids.
Yes. So this
What
is
is the
what
mechanism of action of this HCQ in this Sjogren, sir? How does
this
it
both
affect?
can reduces the amount of the antibody in the plasma, and this is how it reverses likely the pathophysiology of Sjogren.
So we have to
Like
target the
steroid.
antibodies only now.
Yes. But unfortunately, by my knowledge, though I'm not, in the much of Sjogren's, I'm a hemato-oncologist, but I have seen very few patients of Sjogren's in my practice. But so far, there is no specific one antibody which exactly target this antibody and kills this and reverse the pathophysiology. So everybody's trying the immunosuppressant drug, like all autoimmune hemolytic anemia, autoimmune ITP, all other autoimmune SLE. The treatment list is by and large the same, right? You give the steroid. If steroid does not happen, you give some kind of monoclonal antibody and try to block the antibodies. But I am not aware of such kind of specific antibodies against it, right? So I'll look into it. This is Sjogren's just for the general schematic presentation. I love the pictures. So in my presentation, there are hundreds of pictures. Probably also loves. Sjogren's etiology, idiopathic, as you see directly, secondary associated with RA, rheumatoid arthritis, and a primary biliary cirrhosis, right? More common in female than male, right? Anti-Rho SSA antibody, anti-La SSB antibody, and this thing. So here the answer for our this thing is anti-La and SSB antibody seen in which? So Sjogren seen anti-La and SSB. Complication lymphadenopathy, and it increases the risk of lymphoma as well, B cell, right? And transplacental transmission is also possible, antibody. So baby may develop this. The cardinal feature is dry eye, as you see, gland eye, right? Lacrimal xerophthalmia. The word terminology is xerophthalmia, right? And there is a parotid swelling, as somebody told, doctor told already, right? And there is a dental caries, dryness of mouth, so dental. These are the key cardinal features of Sjogren's. So let's go back to the stem of the question, right? So Sjogren's mucous membrane and moisture secreting glands of the eyes and mouth are usually affected first, resulting in decreased tear and saliva, right? And these are the exhaustive list of the antibodies which you need to remember, which you probably, at least more important, let me tell you. So anti-nuclear antibody, that is ANA. So anti-nuclear antibody is right. Anti-nuclear antibodies and the condition in which are associated with the following. So specific, right? ANA positive is general. It can be seen in hundreds of mixed connective tissue disorder, right? Or many autoimmune disease. So ANA once positive, what's your next goal is to do ANA profile. Once ANA positive, you do ANA profile and try to find out the exact antibody which is responsible for the disease. So here the exact anti-centromere antibody, anti-centromere antibody, right? What is the systemic sclerosis? Remember this one liner, but very important. Systemic sclerosis, anti-centromere in systemic sclerosis. Another name is the CREST syndrome. Can anyone tell me what is the CREST syndrome? Includes 5 things in a CREST syndrome. These all are question in exam. You need to widen your horizon of your preparation. You can't do just in the box practice. This reading out of the box you have to read. So if you don't know, you go and read it. What is CREST syndrome?
Calcinosis.
Calcinosis,
Phenomena.
Raynaud's phenomena, esophageal dysmotility, sclerodactyly,
Scleroderma.
Telangiectasis.
Wonderful. Excellent. Wonderful. Then it is in the primary biliary cirrhosis, proximal scleroderma. Anti-dsDNA SLE, anti-dsDNA SLE. SL is anti-dsDNA. Somebody was asking GP210, it is in primary biliary cirrhosis. Already doctor explained primary biliary cirrhosis, GP210. Anti-histone, histone means histamine, histone. SLE, systemic lupus erythematosus and drug-induced. Anti-Jo, right, is polymyositis and dermatomyositis, right? Anti-lion SSB, our scenario, primary Sjogren syndrome, all right? Probably if you don't remember each and everything, just try to remember the important one. So these are the important one. And let me go to the second page as well. This is also important one. So I don't want you to remember hundreds of antibodies, but just remember 510, which is exam oriented. All right. So again, you see anti-SP100 is also primary biliary cirrhosis. Anti-topoisomerase scleroderma, frequently asked question. Anti-CCP, we have just seen in osteoarthritis, rheumatoid arthritis. Anti-CCP is rheumatoid arthritis, most sensitive and specific. Again, is a anti-smooth muscle antibody. ASMA, anti-smooth muscle, autoimmune hepatitis. Very important. Anti-thyroid antibody, Hashimoto's thyroiditis, autoimmune disease. Anti-transglutaminase antibody, celiac disease. ANCA and PNCA. Here the CNCA, Wagner granulomatosis. CNCA positive, CNCA positive. Right? Lupus anticoagulant, SLE. And PNCA. CNCA is a Wagner. CNCA is a Wagner. What is a PNCA? PNCA is here the vasculitis. Michael, Church-Strauss syndrome, systemic vasculitis. So these are the few specific things you little remember. This would be available in the books, or you can see this video later on once again. So all is in front of you. So you need to know little basic antibodies which are present in which condition. That makes probably your job easy. If you allow me, I will discuss one last question, if you allow me. Is that okay?
Yes, sir. Please.
Yes, sir.
Last question, sir. Wonderful. So which of the following prevents the cancer in patient with multiple first degree relative with the breast cancer? Remember, understand the question. Which of the following prevents the cancer in patients with multiple first degree relative with the breast cancer? So simpler language. You have a patient who has a multiple people with the breast cancer in the first degree relative. And now this lady comes to you and asks you, who has no breast cancer, and asks you, what can prevent my breast cancer? Question is prevent cancer, right? So what can prevent the cancer? So say, for example, a mother has a breast cancer, Her daughter comes to you and asks the same question. My mother has a breast cancer. My aunt has a breast cancer, right? My elder sister has a breast cancer. How I can prevent? How I can prevent the cancer, the breast cancer? By doing the BRCA testing, by giving the aromatase inhibitor, by dietary modification and lifestyle changes, by doing the HER2 testing, or by doing the ER and PR, estrogen receptor, progesterone receptor testing. How you gonna reduce this risk of the daughters getting breast cancer who has a multiple first degree breast cancer patient in family? Are you getting me? Yes or no? At least tell me question. If you can't understand, do let me know. Are you getting my question?
Lifestyle modification.
Excellent. Lifestyle modification. So one answer is lifestyle. We'll discuss. So what you change in the lifestyle? Lifestyle modification. Lifestyle modification. So what do you understand by lifestyle modification? Can you little describe?
Low sugar intake.
Low sugar intake. Okay. What else? Lifestyle modification means only just low sugar intake or something else is also there in lifestyle modification. It's important. No? We use this term in day-to-day practice. Day-to-day, even in house, we are, change your lifestyle, improve your lifestyle. Your lifestyle is not good. What do you mean exactly by lifestyle modification? Lifestyle modification means change. Whatever the life you are living now, you and me, we would like to change our lifestyle. So what do you mean? What you want me to
Exercise.
change?
Daily exercises. Fat.
Daily exercise.
Decrease fat intake.
Put the hand on your heart and tell how many people are doing daily exercise. I don't want to answer each and everybody, but put the hand on your heart and ask yourself, are we going to do the? So by my sense, the worst patient in the planet is the doctor. Right? Follow what doctor prescribe, but don't follow what doctor does. Because doctors are the most laziest animal on the planet. They advise, oh, you change your lifestyle, you do that, you do exercise. But are we going to take care of ourselves? Don't take it otherwise. This is not an MCQ, but this is serious issue. So I wish and want every doctor should live at least 80 years. For that, we need to change first our lifestyle. Then we can advise our patient to change their lifestyle. Is that clear? Yes or no? Am I right or wrong? Sorry if I'm little hard on you today, but it's important. It's eye opening. So if you're not doing, so go and read the chapter of lifestyle. I'm not going in detail. Go and read what exactly does mean lifestyle. Go and read it. Now so one answer is lifestyle changes. Anyone else wants to do some BRCA testing or something, what, blah, blah, fancy test? How you gonna reduce? No? It's a very important. And breast cancer is the leading cause of death globally, right? Female has a two cancer. I have excellent PowerPoint presentation on breast and cervical cancer vaccine. Cervical cancer. So I will present once. It's a global burden, especially in female. Breast and cervix is the leading cause of morbidity and mortality globally. And fortunately, screening program for both the cancer, mammogram and pap smear and HPV is available. But unfortunately, no female, no doctors doing for themselves, for their mothers, for their sister. They are never doing. They knows everything, but they don't do. We never do the mammogram for our mother. We never do the pap smear for ourselves, especially the female. Like for male, we never do PSA for male, prostate specific antigen. We never do a stool occult blood for colon cancer. We just advise. That's it. We are a big doctor, so we just advise. We can't follow. Yes. Any comment? Any comment? So one is lifestyle modification. Yes, Dr. Bhakti, any comment? Norman. No one? Is it so difficult question?
Hello.
Yes, yes. Go ahead now. What's your thought
So I
process?
think BRCA testing would not prevent the genes, like it won't prevent cancer happening. But if we do BRCA testing, we can detect it at an earlier stage and then probably do like a modified radical mastectomy or like a lumpectomy to prevent further to prevent cancer from actually happening if we detect it earlier.
Fine. Let me ask you a couple of questions. It's a learning platform. Huh? Don't take it otherwise. So, BRCA testing, first of all, BRCA testing, what is the indication of doing the BRCA testing? In which subsets of the patient you tell them that, okay, this lady required BRCA testing? Is there any criteria for the BRCA testing, or each and every female on the planet need BRCA testing? You got my
No,
question? Yes.
yes, sir, I got your question. Sir, if there is like a family history of like not only breast, but also if you have peritoneal or prostate cancer or
Excellent.
like form of
Super,
breast cancer.
super, super. So some disease, list of the disease, first degree relative have a breast cancer, you must do it. Ovarian cancer, prostate, even pancreatic comes. Recently, I was reading article, pancreatic. So your father, mother, or someone's in a family have a breast cancer. So if the mother has, daughter should do. If mother has ovarian, daughter should do. If father has prostate, son should do. Right? And pancreatic, father or mother, anyone has, you do. Is that clear? Yes or no? So this is one special group of the people where you need it. Is that clear so far? Yes or no?
Yes, sir.
Wonderful. Second questions to you. BRCA testing, right? So they have these people, they deserve, na? Right? Multiple. They what they mention, multiple means more than two, three, four, five. God knows, right? Multiple, and also not second degree, first degree relative have a breast cancer, right? So
Right.
here, so this is the first degree, multiple have, so they deserve BRCA. Once you do the BRCA, what the result will come? If the BRCA is positive, Dr. Bhakti, what you advise to the patient? If the BRCA is negative, what you advise to the patient? Second, next question. So you order the BRCA for someone, right, who has a strong first high risk or first multiple people in the family with the breast cancer or ovarian cancer. You advise BRCA and BRCA is positive. Now what you do?
Then
So mother,
probably
mother has a breast cancer. I told you mother, sister, five people, first degree relative breast cancer. Now this 30 years daughter comes to you and you told, oh, you should do BRCA. This normal healthy that BRCA. Now BRCA of this 30 years female is positive, which is absolutely asymptomatic. Mammogram is normal. PET CT scan is normal. Mammosonogram is normal. Everything is normal. Only BRCA is positive. What you do?
sir, in that case, it makes
So
sense not to go forward for any kind of surgery if they don't have any pathological development of cancer. So yes, it makes sense, sir.
no, no. So what you do? Sorry, I'm just trying to bring
Sorry, yeah.
concept
No, I
clarity
kind
to
of
you.
realized that I was wrong at the point. So yeah, I understand that just if BRCA is positive doesn't mean that you would take any relevant step like surgery or anything to prevent cancer from happening.
It has a role, but I'm just trying to understand your concept so you can advise to your patient. You understand that this is a common scenario, na? Mother comes
Yes.
to you with a breast cancer, and now daughter is also come with a consultation to your office and asking how I supposed to prevent the cancer, what I supposed to do. You need to advise something, isn't it? Yes or no?
Yes, sir.
Right. So what you do? BRCA positive, what you do? If you don't do,
Then
then why
probably
you are doing BRCA? That is also a question.
uh, yeah, no, probably I'll advise like a mastectomy or something.
Excellent. So mastectomy. Third question, right? You are going absolutely fine. I'm just trying to improve your concept, right? You are a brilliant lady, right? So BRCA is important. Number one, you need a BRCA. If BRCA is positive, you told that you want to do now the mastectomy. You want to do the mastectomy. Do you mastectomy, right? And it, all BRCA will develop the breast cancer. All BRCA, what's your concept in your mind? If I have done, right, for a patient who has absolutely no problem, nobody in the family cancer. In 7 generations, there is nobody with the breast cancer. But I did it for my just research purpose. Normal, healthy, young female, BRCA is positive, right? So how I supposed to deal with this patient? Should
Sir,
I
if
go
there
for
is
the
no
mastectomy for
relevant
this lady?
family, no, sir. If they don't have any relevant family history, then I don't think we should go for mastectomy.
Okay, so in that condition, what you advise to the patient? She's a 25 years old girl. What you advise to the patient? She's a
Sir,
brilliant PhD lady, and she's saying, "Sir, I have read an article where they mention the mastectomy. Am I supposed to go for mastectomy at 25 years of age? And this mastectomy, for your kind knowledge, is not unilateral; it's bilateral. Just for your knowledge,
right.
eh? When you are talking
Right.
about mastectomy, it's bilateral because female has two breasts, right? Right, left. So
Right.
you never know, no, which breast develop the cancer down the line, 5 years, 10 years. So if when you are talking about mastectomy, it's bilateral mastectomy. So is it justifiable to do 25 years of age bilateral mastectomy who has a BRCA positive?
No, sir.
Okay, so what advice you do? Okay, so you advise that okay, you don't need a mastectomy. Then patient, this 25 years lady asking you, what am I supposed to take care of? What am I supposed to do down the line to prevent the breast cancer? You
So
got
in
my
that
question.
case, just a normal clinical, like normal breast examination by the patient themselves, and then probably down the line, once they turn like around 45 or 50, they could come for like every annually or twice, like every 2 years, like probably clinical examination of the breast, like by the
Excellent.
physician.
Wonderful, wonderful. So when this lady, right, when you are not going for the mastectomy, you need to advise for the close follow. You need to have, this is high risk. BRCA positive, most of them they develop the breast cancer down the line. They develop the down the line. But when they develop, we don't know. When they develop, we don't know. Right? But there is a very high chance that they develop the breast cancer. So when the female is young, 25, say for example, this lady, so tell them do clinical breast self-examination. That is called BSc, breast self-examination. Every female in this class who, right, must know, right, it prevents and it early detect breast self-examination. Breast self-examination. It is called as a BSc, breast self-examination. Lots of videos available on the YouTube. You can open up any video and then you try to do it, right? Second is a clinical breast examination. And once she grows, right, you need to advise mammogram or mammosonogram. Mammosonogram. This is ideal advice. Number one, right? For those who does not have any family members with the breast cancer, now this patient has a multiple family. So they have two options. One is a medical option, Dr. Bhakti. Medical option means you give something, some drug, which can prevent the breast cancer, or you can do the surgery. The biggest example is Angelina Jolie. Do you know Angelina Jolie?
Yes, sir.
She is a Hollywood big shot star, right? And she has the same thing. She has a BRCA positive. She did a bilateral prophylactic mastectomy. Let me use the word prophylactic. What do you mean by prophylactic? Before the development of the breast cancer, she did it bilateral mastectomy and she did a prosthesis with the silicone on the breast, both the breast, and she's still in the movie. You got my point. And after
Yes, sir.
this, Angelina Jolie, the BRCA 1 and 2 becomes so popular globally, right? That this gene is inheritance. The right. So we must look for the patient who have a the multiple family members with the breast cancer, right? So you must look for the number one BRCA, right? If BRCA is positive, right, you either advise for the bilateral mastectomy. If some patient is young and refuses, then close monitoring, right? And in this patient, Just doing the BRCA will not help to the patient because they have already lots of people in the family with the breast cancer. So dietary modification at all will not going to reduce the risk, right? By changing. Otherwise, nobody will develop a breast cancer in a female by just doing the dietary changes. So dietary changes is not helpful, especially when there is a multiple first degree relative, right? HER2 testing will just give you the idea about whether to give anti-HER2 drug. The name of the drug is trastuzumab. Is that clear? Yes or no? Trastuzumab to give or not? That will guide you, but it will not reduce. By doing this test, will not reduce the risk factor. By doing the estrogen receptor progesterone, will not reduce the risk factor. So what reduces the risk of getting the breast cancer is aromatase inhibitor. So you must give the anastrozole, letrozole, or one other drug. Name of the drug is called tamoxifen citrate. Is that clear? Yes or no? Yes or no?
We should start the drug only if the relatives have the if without testing, sir.
Yes, yes, you can start without the testing. You can start. Why? Because estrogen. Now let me tell you, ask you, maybe it's a whole day lecture for my side in oncology, but breast cancer risk factor. Develop what are the established risk of breast cancer? One of them is a early menarche and late menopause. Have you heard this word?
Sir.
Right? So estrogen is the culprit. Estrogen is a culprit. It increases the risk of breast cancer. If you have excess estrogen in the female or it is menstruating woman means estrogen is there, right? They have increased the risk of breast cancer. What does it mean? If you block the estrogen receptor, if you block the estrogen hormone, then it reduces the risk of breast cancer. Is that clear? Yes or no? At least tell me yes or no.
Yes.
And this is the anti-estrogen. This both are anti-estrogen. It reduces the estrogen. Is that clear? Yes or no? So
Thank you, sir.
BRCA is important, but with this very bad history, just do it. They are saying testing. Testing will not reduce the risk. You understand, right? Testing just not reduce the things. HER2 testing, ERPR testing, this all are important in the treatment, but they are not reducing the risk of developing the breast cancer in a family who has a multiple risk factor. Isn't it? I try my level best to clarify the concept, but still you are open to ask the question. I am doing my level best. So what's the literature? Selective estrogen receptor modulator, tamoxifen, raloxifene, aromatase inhibitor result in 50 to 65% of the reduction in the breast cancer when compared with the placebo. So if you give and if you don't give, 60% plus there is advantage of reduction. The benefit is greatest in those with two first degree relative with the breast cancer, mother or sister. Dietary modification is unproven, will not help, right? In this scenario. In general, answer is yes, but in this scenario, no. HER2 new testing is useful for guiding trastuzumab to give or not, but it will not reduce. Estrogen and progesterone receptor testing has no role in managing asymptomatic woman. This woman is asymptomatic, multiple family members, but she's fine, right? And that's it. So this is what the thing is. And last but not the least, the hereditary risk. Last slide for you. Mutation. BRCA1 and BRCA2 are the tumor suppressor gene, right? It is autosomal dominant mutation. BRCA positive woman develops breast cancer earlier than the woman without the mutation. Dr. Bhakti, you get the point. Very interesting line in this. It's a all take home message, right? So BRCA positive woman develop breast cancer earlier than woman without the mutation, right? So you need to observe this patient. And estimated 55 to 60% of the weakened one with the BRCA1 positive status will develop invasive breast cancer before the age of 70. Can you see this? Yes or no? Are you
Yes, sir.
getting me? Yeah, so BRCA1 positive, 60% of the female develop the very bad, invasive is bad cancer, right? At the age of before 70 and close to 50% with BRCA2. So that is why in clinical practice, I do in my everyday practice, I see a lot of breast cancer in day-to-day practice. So BRCA1 and BRCA2, we do both because BRCA1, if it is present, almost 70% develop before 70 years of age and they are developing at least 50%. So there is a strong genetic correlation between BRCA1 and 2. And last but not the least, those who have a BRCA positive, right, we can give one drug. The name of the drug is olaparib. It is PARP inhibitor. Not going much in detail of pharmacology of hemato-oncology, but this is a PARP inhibitor group of drug, this olaparib, that needs to be given to this patient. So this reduces the risk of recurrence of the breast cancer in BRCA positive population. Is that clear? Is that clear, Dr. Bhakti? I think you little better than before, I guess.
Yes, sir. So, sir, I just had a question. So,
Yes,
olaparib,
please.
if we give it, would it only reduce the risk of breast cancer or like any other like ovarian or prostate or any other cancers that is associated with BRCA?
Wherever there is a BRCA mutation, it works.
Okay, sir.
You got it. Like say for example, another example. Say for example, you know the Philadelphia chromosome, right? And for the CML, yes or no?
Yes, sir.
You know Philadelphia chromosome.
Yes, sir.
Philadelphia chromosome positive. It's a translocation of 922. So primary indication is CML with pH positive. ALL, right? 25% of the pediatric patient with ALL, acute lymphoblastic, they have pH positive. 5 to 10% of adults, they have pH positive. Gastrointestinal stromal tumor, they have pH positive. You understand? So
Yes,
this
sir.
drug, imatinib, the primary drug is imatinib. So it's not just helpful in CML, but it helpful in ALL, also in GIST. Wherever they have a Philadelphia chromosome, they blocks this translocation and try to reverse the pathophysiology. The same thing, olaparib, not only for the breast, for the ovary, for pancreas, prostate, blah. Go on. Is that clear? Yes
Oh,
or no?
yes, sir. Thank you.
Fine. So that's all from my side. Thank you very much all for listening me coolly and calmly and bearing me for 1 hour and 48 minutes. Thank you very much. Before I end up my session, I have hundreds of questions to discuss in every times, but time is the constraint for you and me. So before I end up my session, I would like to have a quick feedback on this things. Probably things are little more tricky and more little toxic. So don't get disappointed by my lecture, but try to improve your preparation and your this hard work. Put more efforts in your preparation. So that's it. So I would like to have little quick feedback on the session. How did you enjoy?
Thanks.
Was anything new learning or something what you makes little more change in the concept clarity or something? Any comment?
Sir, the list of antibodies were really helpful. Some of it I really did not have much idea, but thank you so much for putting it all together in 1 or 2 slides. It was very helpful.
Excellent. I will share in the group. Don't worry. So even if you don't have it, you don't need to waste your time. I prepared a lot. Before I present this session, I do a lot of hard work and smart work as well to compile the slide. It's not in the book. I mean, we need to gather all the slides from the literature and journals.
Thanks, sir.
Yes,
Thank you
any
so much.
comment? You're welcome.
Thank you very much, sir. The multiple different types of question at one platform is getting very, very helpful.
Thanks.
Excellent. Wonderful. Anything else?
Hello. Yeah.
Yes, please.
Yes,
Yeah,
I want.
Jamila, how are you?
I'm fine, thank you, sir. Yes, I want to comment. I've been wanting to comment since, but then I didn't get the opportunity to join.
Yes, yes, please.
The first thing is to thank you very much for the hard work and then going down to the grassroots and then actually this is like an advice to all my classmates that honestly these questions are actually what really comes out in the exams. Actually, as I've written the exams and then I cracked it in the first sitting, and the only resource I used is this resource. Initially I had a lot of books and then lots of things here and there, but then when I joined this session, I understood that it narrowed everything down to the grassroots, and then a great majority of the questions come out from this discussion. Actually, as you were presenting today, you were teaching, it was like I was in the exam hall. I was just remembering all the questions that were asked, which we were discussing and discussing and discussing. So I feel we should really stick to this platform. And then thank you very much, sir, to you and your whole team. Thank you.
Thank you, Jamila. Dr. Jamila recently cracked the exam, so she was sharing to you, your experience, her experience with you. So she recently cracked the DHA, so she will also guide you. So thank you very much once again, everyone, for joining, and let's join and stay tuned with me, and let's connect to the next Sunday once again. Meanwhile, you enjoy the other sessions every day, Monday to Friday, with my colleagues who are specialized in pedia surgery, medicine, gynec. So thank you very much and enjoy your Sunday. Thank you. Thank you very much.
Thank you.
Thank you very much.
Thank you very much, sir.
Thank you.